Vaginal bleeding may affect as many as 40% of pregnant individuals. Most frequently, it occurs during the first trimester of pregnancy, meaning until week 12. But sometimes it can happen during the second or third trimesters, or between weeks 13 and 27, and weeks 28 to 40, respectively. The first step when confronted with vaginal bleeding during pregnancy is to assess the hemodynamic stability of the individual based on the degree of hypovolemia and vital sign status. Stage 1 hypovolemia is when 500 to 1,000 milliliters of blood have been lost. Blood pressure is usually normal, but there may be palpitations, tachycardia, and slight dizziness. Stage 2 is when 1,000 to 1,500 milliliters have been lost. Systolic blood pressure drops to 80 to 100 millimeters of mercury, tachycardia is obvious, and there may be weakness and sweating. Stage 3 is when 1,500 to 2,000 milliliters have been lost. Systolic blood pressure drops between 70 and 80 millimeters of mercury, and there may be restlessness, pallor, and low urine output. Finally, stage 4 is when more than 2,000 milliliters have been lost, systolic blood pressure is less than 70 millimeters of mercury, and symptoms may include cardiovascular and respiratory collapse, loss of consciousness, and anuria. Now, before elucidating the cause, some immediate measures should be taken in order to compensate the blood loss. These follow an ABC pattern. A stands for airway, so you'll want to protect the airway, especially when there's loss of consciousness. B stands for breathing, so you'll want to administer oxygen through a non-rebreather mask. C stands for circulation, meaning measuring vital signs and establishing the degree of hypovolemia, inserting 2 large caliber peripheral IV catheters of at least 14 gauge or even larger gauge, and starting fluid resuscitation immediately with 500 milliliters of normal saline or lactated Ringer solution given over 30 minutes. Afterwards, the rate of fluid is adjusted depending on their hemodynamic status. In individuals who have lost more than 1,500 milliliters of blood, blood transfusions are indicated, typically with products containing both red blood cells and platelets. Next, to elucidate the cause, a full workup including pelvic exam, a transvaginal ultrasound, and laboratory tests should be done. During the first trimester, the most common cause of vaginal bleeding are implantation bleeding, ectopic pregnancy, miscarriage, and genital tract pathology, meaning conditions that affect the cervix, vagina, or uterus. Something to keep in mind is that miscarriage and genital tract pathology may also cause vaginal bleeding in the second trimester of pregnancy. Now, implantation bleeding is the only physiologic cause of first trimester bleeding, and occurs because the developing embryo burrows into the uterine lining 10 to 14 days after fertilization. It presents as light bleeding or spotting that lasts no more than a couple of days, so it's frequently mistaken for the actual menstrual period. Implantation bleeding requires no treatment, but it is a diagnosis of exclusion, so other causes should be ruled out first. The next common cause in the first trimester is an ectopic pregnancy. Now, the rule of thumb, actually, is to assume that vaginal bleeding during the first trimester is caused by an ectopic pregnancy until proven otherwise. With an ectopic pregnancy, the embryo implants somewhere other than the uterine cavity, most frequently the ampulla of the fallopian tube. So risk factors for ectopic pregnancy include previous ectopic pregnancies, previous tubal surgery or pathology, as well as the super rare pregnancies that occur after bilateral tubal ligation, or if the individual currently has an intrauterine device or IUD for contraception. Symptoms include pain and vaginal bleeding that typically begin 6 to 8 weeks into the pregnancy. For diagnosis, a serum HCG can be measured, and if it's above 2,000 milli-international units, or milliunits per milliliter, then the pregnancy, either intrauterine or ectopic, can be seen on transvaginal ultrasound. If the serum hCG level is below that mark, then serial measurements are done every 48 to 72 hours until it reaches 2,000 milli-international units per milliliter. Afterwards, a transvaginal ultrasound can be done to see the ectopic pregnancy, and methotrexate or surgery can be done to terminate the pregnancy. Rarely, the ectopic pregnancy can implant in the cervix, in which case it's referred to as a cervical pregnancy. In this case, vaginal bleeding is often painless and profuse, and often results in hemodynamic instability. Cervical pregnancy is diagnosed with a transvaginal ultrasound, and treatment is to terminate the pregnancy. In hemodynamically stable individuals, termination is done medically with methotrexate. In hemodynamically unstable individuals, immediate evacuation is done through dilation and endocervical curettage. The next possible cause is a miscarriage, and there's two types. Threatened, which means that the embryo may or may not be eliminated at some point, and inevitable, in which case the embryo is definitely going to be eliminated. With a threatened miscarriage, the physical examination shows a closed cervix, and the ultrasound shows an intrauterine pregnancy with detectable fetal cardiac activity. In this case, expectant management is an option until symptoms resolve or there is progression to inevitable miscarriage. Additionally, individuals should avoid vigorous physical activity, heavy lifting, and sexual intercourse. And intravaginal progestins are also given to prevent progression to inevitable miscarriage. With an inevitable miscarriage, the cervix is dilated, vaginal bleeding is increasing gradually, and there may also be painful uterine cramps or contractions. Sometimes gestational tissue can be felt or seen through the cervical opening, and it's usually eliminated in 2 to 4 weeks after diagnosis. So in hemodynamically stable individuals with no signs of infection, expectant management and reevaluation at 4 weeks is an option. After 4 weeks, the inevitable miscarriage can be complete, meaning everything inside the uterine cavity has been evacuated, or incomplete if there's something like placental tissue left behind. For incomplete miscarriages, medical or surgical evacuation are required. In the first trimester, medical treatment is recommended with mifepristone, a progesterone antagonist, and misoprostol, a prostaglandin E1 analog. So 200 milligrams of mifepristone are given orally, and 24 hours later, 800 micrograms of misoprostol are administered intravaginally. If mifepristone is not available, 800 micrograms of misoprostol can be given, and a repeat dose may be given 7 days later if there was no response to the first one. For second trimester miscarriages, surgical treatment is preferred, and it is usually done with dilation and curettage, which is when the cervix is dilated, and then the contents of the uterine cavity are either scraped off with a curette or suctioned out with aspiration. Finally, vaginal bleeding during pregnancy in the first and second trimesters may occur because of vaginal pathology, like vaginitis, vaginal tumors, or warts, cervical pathology, like cervical ectropion or polyps, or uterine polyps or fibroids. Vaginitis can be suspected based on abnormal vaginal discharge, which may be bloody and purulent, and can be diagnosed with a wet mount of vaginal discharge sample. And treatment is usually done with antibiotics. If a vaginal tumor or wart is identified, it's usually removed and then analyzed histopathologically to determine whether it's benign or malignant. Next are cervical pathologies. First, cervical ectropion is when the glandular epithelium of the endocervix is present inside the vagina because of endocervical eversion, which makes the exocervix look bright red on a speculum exam. This is a common, benign finding that occurs in response to hormonal fluctuations during pregnancy. But the columnar epithelium is prone to light bleeding when touched, so bleeding may occur following intercourse or during the speculum examination. No treatment is necessary in this case, but a pap smear should be done to screen for cervical neoplasia, which may present the same. Cervical polyps can also be seen on a speculum exam and can be surgically removed. Uterine polyps and fibroids can be identified with a transvaginal ultrasound. Both are benign masses, but polyps arise from the endometrium, whereas fibroids originate in the uterine smooth muscle. Polyps don't usually cause complications, but large fibroids may cause complications like fetal growth restriction, miscarriage, and preterm birth. Something to keep in mind for later in the course of the pregnancy. Tricky part is that during pregnancy, removing polyps or fibroids carries more risks than benefits, so it's usually done after delivery. If at any point the fibroids become too painful, pain management can be done with acetaminophen. Alternatively, short courses of NSAIDs like ibuprofen can be given for up to 48 hours in pregnancies less than 32 weeks. One final cause of vaginal bleeding in the second trimester for pregnancies less than 20 weeks is cervical insufficiency, which is when there's cervical dilation and effacement, which means thinning, too early in the pregnancy. Other symptoms may include vaginal fullness, pelvic pressure or discomfort, and lower back pain. Now, the diagnosis can be made based on clinical examination, obstetrical history, or ultrasound findings. So first, let's look at the clinical signs. These include cervical dilation and effacement, and fetal membranes may be visible through the cervical opening or protrude into the vagina in the absence of uterine contractions. Second, the diagnosis can be made based on obstetrical history, which means that the individual has had 2 or more consecutive second trimester pregnancy losses or extremely preterm births at less than 28 weeks, with or without signs of cervical insufficiency. Finally, the ultrasound-based diagnosis is made in individuals with a cervical length less than 25 millimeters. Cervical insufficiency is treated with cervical cerclage, which is when a strong suture is sewn into and around the cervix. This is done between weeks 12 and 14 in females with an obstetrical history of cervical insufficiency, or before week 24 of gestation in females diagnosed based on physical examination or ultrasound. Now lastly, in pregnancies more than 20 weeks along, there are a couple of worrisome causes for vaginal bleeding. These include painless causes, like placenta previa, which is when the placenta attaches near or over the cervical opening, and vasa previa, which is when fetal blood vessels that are present in the membranes cover the internal cervical opening, as well as painful causes, like placental abruption, which is when the placenta prematurely detaches from the uterine wall, and uterine rupture, which is exactly what it sounds like. One thing to bear in mind is that digital examination of the cervix during the second half of pregnancy should be avoided, because in the case of placenta previa, this may cause immediate massive hemorrhage. That being said, placenta and vasa previa are 2 conditions that are classically painless and occur in the absence of uterine contractions, and they're both diagnosed with a transvaginal ultrasound. The ultrasound can classify placenta previa into 4 grades depending on the distance from the cervical opening. Grade 1 placenta previa is called a low-lying placenta because while the placenta is in the lower uterine segment, its lower edge is 0.5 to 5 centimeters from the cervical opening. Grade 2 is called marginal previa because placental tissue reaches the margin of the cervical opening but doesn't cover it. Grade 3 is called partial previa because the placenta partially covers the cervical opening. And grade 4 is called complete previa, and it completely covers the cervical opening. Management depends on hemodynamic stability, fetal heart rate, and gestational age. But in the end, delivery is almost always done through C-section. In hemodynamically stable individuals, when the fetus has a normal heart rate, in pregnancies less than 34 weeks, expectant management is advised. A course of antenatal corticosteroids are given to help the fetal lungs mature, and the C-section may be done in weeks 36 or 37. An emergency C-section during the expectant management period is indicated if labor starts on its own, if fetal heart rate becomes concerning, or if there is severe and persistent vaginal bleeding to the point that maternal hemodynamic stability can't be maintained, or if there is significant vaginal bleeding after 34 weeks of gestation. Now, vasa previa, on the other hand, is classified as type 1 or type 2 depending on how fetal vessels came to be in the membranes covering the cervical opening. Type 1 vasa previa is associated with a velamentous umbilical cord, which means that the umbilical cord inserts into the fetal or chorioamniotic membranes rather than the center of the placenta where it's supposed to. Type 2 vasa previa is associated with a bilobed placenta, which is when the placenta has two equal-sized lobes connected by a thin sheet of chorionic tissue. If one of the lobes is significantly smaller than the other, then it's called a subcenturiate lobe. Diagnosis of both type 1 and type 2 vasa previa is done with a color Doppler ultrasound that will show fetal vessels passing across or in close proximity to the internal cervical opening. Management requires a course of antenatal corticosteroids between weeks 28 and 32, and starting with week 32, a weekly non-stress test or NST is performed. An NST is a 20-minute recording of fetal heart rate using a cardiotocograph, also called an electronic fetal monitor. On a normal NST, fetal heart rate varies between 110 and 160 beats per minute, and has at least two accelerations defined as increases of 15 beats per minute in fetal heart rate, lasting for more than 15 seconds in pregnancies beyond 32 weeks, or 10 beats per minute lasting for at least 10 seconds in pregnancies below 32 weeks. Hospital admission is recommended between weeks 30 and 34, during which an NST is done 2 or 3 times each day. Okay, now during this management period, an emergency C-section may be performed if labor starts, if the fetal membranes rupture prematurely, if vaginal bleeding is severe enough to cause maternal hemodynamic instability, or if the NST shows decelerations, fetal tachycardia, or if the blood that's coming out of the vagina is demonstrated to be pure fetal blood with the APT test or the Kleihauer-Betke test. Okay, now finally, there's placental abruption and uterine rupture, which are the painful causes of vaginal bleeding after 20 weeks of pregnancy. Let's look at placental abruption first. Risk factors include prior placental abruption, trauma, smoking, hypertension, cocaine use, and premature rupture of membranes, or PROM. Bear in mind that blood loss may be underestimated, as blood can pool behind the placenta. This means, in some cases, there may just be light or no vaginal bleeding at all. Depending on clinical symptoms, placental abruption can be mild when the placenta has only partly separated from the uterine wall, or moderate, or severe when there is complete separation. In mild cases, there may be a small amount of vaginal bleeding, uterine tenderness, and there are no changes in hemodynamic status and no signs of fetal distress. Mild placental abruption can be managed conservatively, and individuals are hospitalized for close monitoring. A course of antenatal corticosteroids can be given in pregnancies less than 34 weeks gestation, and delivery can be done after 36 weeks, or if there is a deterioration in maternal or fetal status. Next, with moderate placental abruption, there may be moderate vaginal bleeding, significant uterine tenderness and uterine contractions, and signs of hemodynamic instability and fetal distress. With severe placental abruption, there may be heavy vaginal bleeding, a tetanic uterus, which has a board-like consistency on palpation, and maternal shock or fetal death may occur. Additionally, severe placental abruption may progress to disseminated intravascular coagulation, or DIC, which uses up platelets and clotting factors so that normal hemostasis can't occur. so lab work would also show low fibrinogen levels, a high INR, a prolonged PT and PTT, and low platelets. For moderate and severe abruptions, delivery is usually indicated immediately. Finally, uterine rupture is a rare cause of vaginal bleeding during pregnancy, and one risk factor is having had a previous C-section. It's usually a result of abdominal trauma, but rarely it can occur without any precipitating cause. Just like with placental abruption, the amount of blood that's coming out of the body through the vagina may be misleading, but in this case, blood may spill into the peritoneum instead. Symptoms include sudden onset abdominal pain, maternal hemodynamic instability, or fetal heart rate abnormalities, and if present, these warrant an emergency C-section delivery. Sometimes, after the fetus has been delivered, the surgeon may try to suture the uterus back, but most of the time, a hysterectomy, which is when the uterus is removed, is done. Alright, as a quick recap, vaginal bleeding during the first trimester can be caused by implantation bleeding, ectopic pregnancy, miscarriage, and genital tract pathology, with the last two also being causes of vaginal bleeding during the second trimester. Implantation bleeding presents as light bleeding and requires no treatment, but it is a diagnosis of exclusion, so other causes should be ruled out first. Ectopic pregnancy should always be ruled out first. It usually implants in the ampulla of the fallopian tube, but it can rarely implant in the cervix. No matter the location, it can be seen on transvaginal ultrasound when serum HCG levels are above 2,000 milli-international units per milliliter. And methotrexate or surgery can be done to terminate the pregnancy. Miscarriages can be threatened when the cervix is closed and the ultrasound shows an intrauterine pregnancy with detectable fetal cardiac activity, or inevitable when the cervix is dilated, vaginal bleeding is increasing, and there may be uterine contractions. Expectant management is an option for threatened miscarriage until symptoms resolve, or there is progression to inevitable miscarriage. With an inevitable miscarriage, expectant management is an option in hemodynamically stable individuals with no signs of infection. After 4 weeks, the inevitable miscarriage can be complete or incomplete, and for incomplete miscarriages, medical or surgical evacuation are required. Another cause of bleeding in the second trimester for pregnancies less than 20 weeks is cervical insufficiency, when there's cervical dilation and effacement too early in the pregnancy. And fetal membranes may be seen through the cervical opening, but there are no uterine contractions. This is treated with cervical cerclage before week 24 of gestation. In pregnancies more than 20 weeks along, painless causes of vaginal bleeding include placenta previa and vasa previa, whereas painful causes include placental abruption and uterine rupture. Placenta and vasa previa are diagnosed with an ultrasound that shows the placenta, or respectively the fetal vessels covering or in close proximity of the cervical opening. In both cases, management depends on hemodynamic stability, fetal heart rate, and gestational age. But in the end, delivery is almost always done through C-section. Placental abruption can be mild, moderate, or severe. Individuals with mild placental abruption can be hospitalized and managed conservatively, whereas an immediate delivery is indicated for moderate and severe abruptions. Finally, uterine rupture warrants an emergency C-section.